So if you are in perimenopause right now and you've noticed that your migraines have suddenly become just completely unbearable, well, you are definitely not imagining it.
No, absolutely not. I mean, the research is actually showing that your brain might literally be falling off a hormonal cliff about 30% faster than someone who doesn't get migraines.
30%. I
Yeah.
mean, that is a staggering biological shift. And it's one that leaves, millions of people wondering why their usual pain meds suddenly stopped working.
Right. Up to 62% of women with a history of migraines notice these distinct, often really severe changes in their headache patterns during the perimenopausal transition.
Wow, 62%. So for today's deep dive, our mission is pretty straightforward. We're tackling the biological perfect storm happening in your body right now.
And more importantly, mapping out the evidence-based strategies to actually find you some relief.
Exactly. Because we've pulled from a really massive stack of sources today. We've got guidance from NHS Scotland, clinical recommendations from the Association of Migraine Disorders,
Yeah.
rigorous research from the NIH, and vital insights from the British Menopause Society.
Yeah, and looking at all this data together, the starting point is really getting past that old school medical brush off. For the longest time, the clinical narrative was just this vague, well, hormones cause headaches.
Rather, it's just a given.
Exactly. But the reality is highly mechanical. I mean, to understand why your head is throbbing more than it used to, we really have to look at the unique structural relationship between your brain and estrogen.
Okay, let's unpack this, because this is where the biology gets really visual. Think of estrogen like like a volume knob for pain sensitivity in your brain.
That's a great way to picture it.
Right. So throughout your regular reproductive years, that volume knob moves up and down in a fairly predictable monthly rhythm. Your brain gets used to that rhythm. But during
It's
perimenopause,
pure chaos.
exactly. It's as if someone has walked up to the amplifier and is unpredictably twisting that volume knob wildly up and down, cranking it to 10, dropping it to 2, back up to 8. It makes the brain's pathways incredibly hypersensitive to any kind of pain.
And that volume knob analogy is perfectly aligned with the foundational concept here, which is called the estrogen withdrawal hypothesis.
Estrogen withdrawal.
Yeah. It was first proposed by a researcher named Brian Somerville back in 1972, and his breakthrough was realizing that it isn't the absolute baseline level of estrogen in your blood that triggers a migraine attack.
Oh, interesting. So it's not just having low estrogen.
Right. It is the drop. It's the chaotic, rapid fluctuations.
Wait, but if it's just the drop, why does it specifically cause head pain? Like, why doesn't an estrogen drop make my knee throb or, my elbow ache?
Well, it really comes down to real estate. Estrogen receptors aren't just localized in your reproductive organs. They are actually densely packed inside your brain, specifically along a network called the trigeminovascular system. That is the primary neural superhighway responsible for transmitting pain and temperature signals from your head, your face, and the blood vessels surrounding your brain.
So when estrogen levels swing wildly, the nerves along this specific superhighway just become highly excitable.
Exactly. They start firing off pain signals at the absolute slightest provocation.
So the superhighway is basically electrified. And on top of that, it loses its natural braking system, right? Because the sources point out that when estrogen plummets, it actually drags serotonin down with it.
Which is just a brutal double whammy for the nervous system because serotonin is your brain's natural pain regulator. It acts as the dampener.
Like a shock absorber.
Yes. So the volume knob for pain is being turned up by the estrogen drop, and your body's natural painkiller, the serotonin, is being removed simultaneously.
That sounds miserable.
It is. And this loss of serotonin is also why you don't just feel localized pain, but you experience that heightened, almost unbearable sensitivity to light and sound. The brain has literally lost its natural sensory filters.
And this brings us back to that wild statistic from the top of the show. The NIH research shows that if you have a history of migraines, like maybe you got them around your period in your 20s and 30s, you actually experience a 30% more rapid rate of estrogen decline during your cycle than women without migraines.
Yeah, it's a profound neurological disadvantage. Your brain barely has time to adjust to the new hormone level before it shifts again.
Wait, is the brain biologically changing how it processes the hormone, or are the ovaries just shutting down erratically?
Well, if we connect this to the bigger picture, it appears to be a systemic neuroendocrine vulnerability. So the ovaries are fluctuating erratically, yes, which is standard for perimenopause. But the migraine brain is fundamentally wired to overreact to those changes.
Oh, I see.
The threshold for what the brain perceives as an emergency is just set much, much lower.
So you have this hyper-excitable pain highway, disappearing serotonin, and an estrogen cliff you're falling off 30% faster. But, perimenopause doesn't happen in a vacuum.
Definitely not.
If the brain is already that hypersensitive, what happens when you throw the other classic perimenopause symptoms into the mix?
You get a compounding domino effect. Estrogen withdrawal is the primary trigger, sure, but it sets off secondary symptoms that lower your body's migraine threshold even further. Take sleep disruption, for example.
Ugh, the insomnia.
Right, insomnia and night sweats create a vicious cycle because a sleep-deprived brain really struggles to clear out metabolic waste, which significantly lowers its resilience to pain.
So a trigger that might not have caused a migraine after a good night's sleep will absolutely cause one after a night of sweating and tossing.
Exactly. And then you have the menstrual changes because perimenopause periods aren't just irregular. They can be incredibly heavy.
And the physical act of a heavy period releases inflammatory compounds,
Yeah.
prostaglandins.
Yes. Prostaglandins are essentially what cause the uterine muscles to contract and cramp. But they don't just stay in the uterus, they actually enter the bloodstream.
And since they're highly inflammatory, they travel up to the brain.
You got it. They travel up and can directly irritate that exact same trigeminovascular highway we talked about earlier.
Man, that is rough. And we cannot ignore the hot flashes either. The sources highlight this phenomenon called the climax headache, which happens at the exact peak of a hot flash.
Yeah, so a hot flash is a massive sudden vasodilation. Your brain mistakenly thinks your body is overheating, so it forces your blood vessels to rapidly expand to release heat.
But for someone prone to migraines, that sudden, intense expansion in the blood vessels of the head.
It leads to a rapid, severe throbbing sensation. It's essentially a vascular headache triggered in real time by a temperature regulation glitch.
Okay, let me push back here for a second. Because someone listening might be thinking, look, perimenopause is just stressful. I'm not sleeping, I'm sweating, I'm moody, my boss is annoying me. Are these just typical tension headaches from the sheer stress of this life transition? And we are overcomplicating it.
What's fascinating here is that it's a completely fair question, and honestly, a lot of doctors make that exact same assumption. They just write it off as stress.
Which is so frustrating.
It is. But biologically, the pain profile is absolutely changing. These are physiologically distinct from standard pension headaches, and they are even distinct from the migraines you may have had in your 30s.
How so?
The data emphasizes that perimenopausal migraines tend to last longer, they're rated as significantly more severe on pain scales, and they are frequently more resistant to standard acute treatments.
Which is incredibly validating to hear if you've been wondering why your usual over-the-counter meds are doing absolutely nothing. You aren't just fighting a headache, you're fighting a systemic hormonal storm.
Precisely. Which brings us to the most common question patients ask. When does the storm end?
Right.
If the fluctuations are causing the pain, what happens when menopause is fully established?
Well, there is definitely a myth out there that the second you hit menopause, the clouds part, the angels sing, and your migraines magically vanish forever.
Yeah, the reality requires a bit more patience. Medically, you are officially in menopause only after you've gone 12 full consecutive months without a menstrual period. Everything before that 12-month mark is perimenopause.
And the timeline for migraine relief doesn't magically align with that 12-month anniversary, does it?
No. The sources show it typically takes anywhere from 2 to 5 years post-menopause for your hormones to fully stabilize at their new lower baseline.
Wow, up to 5 years.
Yeah, it takes time for the brain to adapt to the silence after the volume knob stops moving.
Here's where it gets really interesting.
Mm-hmm.
We can look at natural menopause like a dimmer switch. Over a period of years, that dimmer switch is slowly, gradually turning down the power on those hormone fluctuations.
Right.
And because it's a gradual dimming, your brain has time to adapt to the lower light. Once that dimmer switch finally settles into the off position, about 2/3 of women see their migraines significantly improve or cease entirely. 2/3.
That is a profound message of hope, but we really must heavily contrast that natural dimmer switch with surgical menopause.
Oh, right.
Surgical menopause occurs when the ovaries or uterus are surgically removed, such as through an oophorectomy or a hysterectomy.
And if natural menopause is a dimmer switch, Surgical menopause is like ripping the power cord straight out of the wall.
That is exactly what happens neurologically. There is no gradual decline. Your estrogen production drops to near zero overnight.
And the statistics here are pretty stark.
Very. While two-thirds of women improve after natural menopause, 67% of women experience worsening migraines after surgical menopause.
Ouch.
Yeah. The abruptness of that hormone drop severely shocks the brain's pain pathways.
It's a brutal transition. And it's something that absolutely must be a part of the conversation if you and your doctor are considering surgery. You have to factor your migraine history into that decision.
Absolutely. The brain simply does not tolerate sudden endocrine shocks well.
So what does this all mean? Let's transition from the problem to the toolkit. Because if you are sitting right in the messy middle of perimenopause, what can you actually do? Let's start with the most direct approach to the hormone problem. Hormone replacement therapy, or HRT.
This is an area where old medical dogma has done a lot of harm. For a long time, women with migraines were told they could never, ever touch HRT because it would increase their risk of having a stroke.
But the updated guidelines, specifically the statements from the British Menopause Society we reviewed, completely rewrite that narrative.
They do. The fear of stroke was primarily associated with older, high-dose oral synthetic estrogens, because when you swallow an estrogen pill, it has to be processed by your liver.
Which creates a massive spike of estrogen in your blood, right?
Exactly, followed by a steep valley as the pill wears off. And what did we learn earlier? Fluctuations trigger migraines. The pill was inadvertently recreating the roller coaster.
So instead of a roller coaster pill that spikes your system, the gold standard now is the patch, which is basically like an IV drip of stability.
Precisely. Transdermal estrogen, meaning patches, gels, or sprays applied directly to the skin, is absorbed continuously. It delivers a low, steady, stable stream of hormones into your bloodstream. It entirely eliminates those peaks and valleys.
That's a game changer.
And the British Menopause Society explicitly states that transdermal HRT does not increase stroke risk in women with migraines, even those with migraine with aura.
It essentially tapes the volume knob in place so it can't be twisted anymore. But, HRT isn't the right fit for everyone.
Yeah.
So let's talk about the pharmacological options, because the terminology here could be really confusing. The sources talk about using NSAIDs or triptans as a mini prophylactic.
Let's break that down. A prophylactic is just a medical term for a preventative. So if your perimenopause cycles are still somewhat predictable, doctors will sometimes have you take a specific medication a few days before your period is due and continue for a few days after it starts.
Oh, I see. You are building a chemical shield before the pain even has a chance to begin.
Exactly.
Wait, so you aren't waiting for the pain to hit. You just start taking an over-the-counter NSAID, like naproxen, early.
Yes, because NSAIDs actively block the production of those inflammatory prostaglandins we discussed earlier. If you stop the uterus from flooding the bloodstream with prostaglandins, you protect the brain.
That makes total sense.
Alternatively, doctors might prescribe a long-acting triptan, like frovatriptan. Triptans work differently, though. They actively calm the nerves in the trigeminal superhighway and constrict the blood vessels to stop them from throbbing.
But what if you were just totally exhausted by taking pills? I mean, between vitamins, pain meds, and everything else, pill fatigue is incredibly real during perimenopause.
Very real. And this is where the innovation in neuromodulation devices is so exciting.
Right.
These are FDA-cleared wearable devices. Some you place on your forehead, others on your arm or neck. Devices like Nerivio, Cephaly, or GammaCore.
How does an armband stop a headache, though? Honestly, that sounds like science fiction.
It kind of does, but it relies on something called the gate control theory of pain. Imagine you bang your elbow on a door frame. Your instinct is to immediately rub it, right?
Oh, yeah. Always.
The physical sensation of rubbing travels to your brain faster than the throbbing pain signal, effectively closing the gate on the pain. Neuromodulation devices do this electronically.
Really?
Yeah. They send highly specific, mild electrical pulses that stimulate non-painful nerve pathways. These pulses race up to the brainstem and physically intercept and block the migraine pain signals traveling along the trigeminal nerve.
Wow.
They treat the migraine neurologically without adding any systemic chemicals to a body that's already in chemical chaos.
That is fascinating. It's physically jamming the signal. And, speaking of the cellular level, we have to talk about basic brain energy. Because the Brain Ritual article in our stack really highlights how estrogen decline creates an energy crisis inside your brain's mitochondria.
This raises an important question about how our cells function. Mitochondria are the powerhouses of your cells, right? They generate ATP, which is pure cellular energy. Well, estrogen plays a huge role in helping your brain's mitochondria run efficiently.
So as estrogen drops,
Your brain literally has a harder time producing energy, and a brain cell without enough energy struggles to maintain its defensive barriers, making it hyper-reactive to pain.
so if you can't rely on estrogen to help make that energy, you have to supply alternative raw materials, which is where the nutrient support comes in. The data strongly supports supplementing with magnesium, specifically 400 to 600 milligrams daily, because magnesium naturally regulates blood vessels and calms neural excitability.
Yes. Along with riboflavin, which is vitamin B2 at 400 milligrams, and CoQ10.
And they help with the energy production.
Exactly. You can think of riboflavin and CoQ10 as actual jumper cables for your mitochondria. They participate directly in the chemical reactions that create ATP. By supplementing them, you are giving your brain alternative pathways to produce cellular energy even when estrogen isn't there to help.
So what does this all mean? We have patches, tryptan shields, armbands that jam pain signals, and mitochondrial jumper cables. If you are overwhelmed by options, how do you figure out what works for your specific body?
You really have to become a data scientist of your own biology, and the most powerful tool for that is a comprehensive symptom diary, but not just a generic note on your phone that says headache today.
Right, because we are looking for the dominoes.
Exactly. You need to track your headaches, but also the severity of your hot flashes, the exact quality of your sleep, and your bleeding patterns. For instance, you might discover through tracking that you only get a blinding migraine when a night of poor sleep from night sweats is followed by a skipped breakfast and a hot flash the next afternoon.
That is a highly specific biological domino effect.
It is. But once you map your unique pattern, you and your doctor can target the specific trigger. Maybe it's treating the night sweats first to stop the whole chain reaction.
Okay, I'm tracking with the hormonal dominoes, but my brain immediately goes to worst-case scenarios. If I'm keeping my diary and I'm, say, 52, and I suddenly get a blinding headache that I have never, ever felt before, or, sorry, I mean, if I've never felt it before, is it safe to just blame menopause?
No, absolutely not. And that is a critical distinction to make. While perimenopausal migraines are incredibly common, there are strict red flags that require immediate medical evaluation.
Good to know.
If you experience a sudden explosive headache, what neurologists call a thunderclap headache that reaches maximum excruciating intensity within seconds or minutes, you need to seek emergency care. Do not wait.
Because it could be something vascular, right, like an aneurysm.
Exactly. Additionally, if you are over the age of 50 and you suddenly develop a brand new type of headache that you've never experienced in your life, that is a major red flag.
What about other symptoms happening at the same time?
Yes. If your headache is accompanied by new neurological symptoms like sudden weakness on one side of your body, slurred speech, or vision loss that feels very different from a typical migraine aura, do not assume it's just your hormones. Get it evaluated immediately.
So let's pull all of this together. The core message we want you to take away from this deep dive is a message of genuine hope. You are currently navigating an exhausting biological transition. Your brain is dealing with an unpredictable volume knob, the loss of its natural pain dampener, and a compounding cascade of secondary symptoms.
It's undeniably hard.
It really is.
Yeah.
But it is temporary. For the vast majority of women, profound relief is waiting on the other side once those hormones finally stabilize. 2/3 of you will see these migraines dramatically improve once that dimmer switch is finally turned all the way down.
The biology will eventually find its new balance. The key is utilizing the right evidence-based tools, whether that's transdermal HRT, neuromodulation, or targeted nutrients to bridge the gap safely until it does.
But before we wrap up, there is one final, lingering thought I want to leave you with, inspired by some of the cutting-edge NIH research in our stack. Throughout this entire conversation, we've been laser-focused on estrogen and progesterone, the sex hormones.
Because they are the loudest, most obvious culprits in the room.
Exactly. But recent studies show that when estrogen drops so sharply right before a period or during these perimenopausal shifts, it actually drags two other hormones down with it, oxytocin and vasopressin.
Oh, wow.
Yeah. Oxytocin is famously known as the love hormone. It's the chemical responsible for bonding, feelings of safety, and emotional connection. And vasopressin helps regulate water and stress. Both of them drop off a cliff right alongside estrogen.
Which opens up a truly fascinating new frontier in how we understand pain.
Exactly. Could the future of treating these midlife migraines lie not just in replacing sex hormones or taking painkillers, but in understanding how the brain's deepest bonding and stress hormones actually modulate our perception of physical pain. I mean, if a sudden drop in the love hormone makes our nervous system feel physical pain more acutely, what does that tell us about how deeply intertwined our emotional and physical networks truly are?
It suggests that our entire definition of pain management might be far too narrow.
It's definitely something to mull over the next time you're navigating a migraine day. Thank you so much for joining us on this deep dive. We highly encourage you to take these insights, particularly about transdermal HRT, mitochondrial health, and finding your unique trigger combinations, and discuss them with your own healthcare provider.
Absolutely. Knowledge is most valuable when you can take it and apply it to your own life.
And remember, getting a clear diagnosis during perimenopause can often feel incredibly murky, like looking at a broken X-ray machine. But hopefully, by understanding the very real, highly mechanical fluctuations happening in your brain right now, that invisible pain feels a little less mysterious, and your path toward relief feels a lot more clear. Until next time.